Hello again. We will talk here about tumors of the endocrine pancreas, and so this means tumors of the pancreas cells that release hormones. So this is not about pancreatic adenocarcinoma, which is the commonly referred to pancreatic cancer. So these tumors as a whole are much more rare than pancreatic cancer, or pancreatic adenocarcinoma. Nevertheless, they warrant being talked about. The two most common, which make up about 80%, are the Insulinoma and Gastrinoma, so we're going to talk about those in most detail. And then the remaining 20% are made up primarily of the VIPoma, vasoactive intestinal peptide, OMA, which is about 15% of those, and then Glucagonoma and somatostatinoma are extremely rare, but we will just briefly talk about that. Okay, so just sort of reviewing the physiology. There are multiple different kinds of cells in the pancreas that are responsible for secreting different hormones. First off, we have the alpha cells, and these secrete glucagon. Glucagon is the opposite of insulin, and so glucagon raises our blood sugar, and the way it does that is by stimulating gluconeogenesis in the liver and by stimulating lipolysis, which will break fats down into sugars, which can then be broken down into smaller parts, which ultimately will become glucose. So glucagon is secreted when the blood glucose level is low. So it has the effect of raising our blood sugar. Beta cells secrete insulin, and so insulin, as you are probably aware, stimulates the cellular uptake of glucose, which can then be used for metabolic activity. And it's normally secreted after a meal. There are people who don't secrete insulin, such as type 1 diabetics. However, in most people, insulin is secreted after a meal, and then it has the effect of lowering the blood sugar. Delta cells secrete somatostatin, and somatostatin is, you can think of as the master off switch. It suppresses the release of GI and pancreatic hormones, such as glucagon and insulin. It also has an effect in the hypothalamus and in the pituitary by reducing the release of growth hormone, releasing hormone, and thyroid stimulating hormone. Gastrin is released by the G cells, or gastrin cells, which exist in the stomach and the duodenum as well as the pancreas. And what gastrin does is it stimulates the release of hydrochloric acid by the parietal cells. And so this will lower the pH in the stomach, which allows for digestion. So the insulinoma is a tumor of functioning pancreatic beta cells. Remember, the beta cells create insulin. And 80 to 90% of insulinomas are benign, but that doesn't mean they don't cause really bad problems. So what would you expect in a patient who has a tumor that's secreting a lot of insulin? You would expect hypoglycemia. What is a hypoglycemic episode? Patients with insulinoma present with hypoglycemic episodes. So if you want to know what a hypoglycemic episode is, you should think of how it would feel. And I can tell you exactly how it feels. If you know what it's like waking up in the middle of the night where you're hungry, you want something to eat, something sugary, maybe a soda or a bite of ice cream or cake or something, and you just get that craving and you've got to get out of bed, it's like that, but times 10. It's way worse than that. It's severe. And so they get this hypoglycemia, and along with cravings for sweets, they a lot of times have the sympathetic discharge, which includes tachycardia, palpitations, sweating, anxiety, even behavioral changes, and if it gets severe enough, loss of consciousness and coma. And so these symptoms, when they're present, are always associated with the hypoglycemia. They're never present with a normal blood sugar. So how do these patients get hypoglycemia? Well, it's during fasting. And fasting for patients with an insulinoma is not very long. So when you and I think about fasting, we think of 8 or 12 hours maybe. For these patients, fasting could be 1 or 2 hours. So there's the Whipple's triad for insulinoma. Mr. Whipple, Dr. Whipple must have done a lot because he's got a lot of things named after him. But the Whipple's triad for insulinoma, are 3 diagnostic criteria you can use to pretty much secure a diagnosis of insulinoma, as long as you rule out a couple things that we'll talk about. But there's 3 things. So 1, it's precipitated by fasting. And like I said, that's pretty easy to do when you have insulinoma. Number 2, the episodes are associated with hypoglycemia. So hypoglycemia meaning 60 milligrams per deciliter. Remember, the normal blood glucose level is roughly 60 to 100. And number 3, most importantly, it's relieved by oral or IV administration of glucose. So you put those 3 things together and you know that you have a hypoglycemic episode, which is caused by a high level of insulin. So there is another thing, though, that can cause a hypoglycemic episode. As you can imagine, if you have exogenous insulin. Let's say, for instance, you're a brand new type 1 diabetic patient and you accidentally take too much insulin. You take 10 units instead of taking 5 units. Whoops. Now you're going to have a hypoglycemic episode because you've got too much insulin. Another way you can get it, and we see this a lot, is factitious hyperinsulinemia. And that would be a patient that is not prescribed insulin, that somehow gets a hold of insulin and injects it, either because they want medical attention and the care, like in Munchausen syndrome, or because they want to get out of work or something secondary like that, which would be malingering. So you can have factitious hyperinsulinemia as well, so iatrogenic or factitious. So how do we differentiate iatrogenic? Well, what do they have in common? The iatrogenic and factitious and hyperinsulinemia and the insulinoma. They all are going to have elevated insulin. So when you're diagnosing an insulinoma, the best initial diagnostic test is an insulin to glucose ratio. And so if it's high insulin, of course, we're going to have a high insulin to glucose ratio. So a greater than 0.4 ratio is suspicious for insulinoma. But you have to get a C-peptide level, and the C-peptide level is done to distinguish an insulinoma from factitious hyperinsulinemia. I mean, usually if it's iatrogenic hyperinsulinemia, we can ask the patient, did you take your insulin? How much did you take? But if it's a patient who denies taking insulin, we still have to make sure that it's not factitious hyperinsulinemia. So we get a C-peptide level. What is C-peptide and what does it do and why is it there? Well, it really doesn't do anything. But when you secrete insulin, what you first make is proinsulin. And proinsulin is just a insulin with a little tail on it. And before it becomes insulin, that little tail gets chopped off, and that tail is C-peptide. Now, when you get insulin over the counter, when you're injecting it, that C-peptide is not there. So if you are taking insulin and injecting it, you'll have a low C-peptide level relative to the insulin that you have. You'll have a high insulin level, but a low C-peptide level. But if your body is creating too much insulin, you'll have a high insulin level and a high C-peptide level to match. So the C-peptide level is important because it helps us differentiate too much insulin secretion versus the patient is getting too much insulin from outside the body. So for diagnosis, once we've got that high insulin to glucose ratio and a C-peptide level that matches it, then we can go on and get a CT scan. And the CT is done with contrast. We're looking for arteries, and we're looking for a mass. And usually, in most cases, this will visualize the insulinoma. However, if it doesn't, there are other tests you can do. Arteriography, but that's usually not done. What we usually do if the CT doesn't find it is an endoscopic ultrasound of the pancreas. And that's actually the most accurate test for diagnosing an insulinoma. Once you formally diagnose the patient with an insulinoma, then the best treatment is a surgical resection with a biopsy. And there's a 65% cure rate with surgery, but there's a 10% operative mortality. So this is not an insignificant surgery. If the insulinoma happens to be malignant, it's actually got a somewhat bleak prognosis compared to a benign insulinoma. There's about a 60% survival at 2 years. Okay, so another thing that I wanted to bring up is something called nesidioblastosis, and this is a condition of pediatrics in very, very young babies, and this is a condition of hyperinsulinism, but it's due to beta cell hyperplasia. And so with nesidioblastosis, what you typically see, and this can also be called congenital hyperinsulinism, but what you typically see is jitteriness and lethargy. You may also see episodes of hypothermia and even convulsions or seizures. A lot of times these babies had a history of macrosomia in utero, and so they're large for gestational age. And that's because if you've got too much insulin, you're taking up more sugar, and so you're getting bigger. And so the way you diagnose these babies is pretty much the same way. You just get an insulin level during an episode of hypoglycemia. If they actually have any insulin whatsoever during hypoglycemia, that's virtually diagnostic. The best imaging for babies, though, is PET scan. And I think that has some difference. So it'd be a little bit more difficult to see the pancreas and the hyperplasia. The major complication out of nesidioblastosis is brain damage, of course, due to low blood sugar, and that can happen in anybody. You can get brain damage to some extent from low blood glucose levels, but definitely children are at a much greater risk. And the treatment for nesidioblastosis is a subtotal pancreatectomy. So the problem here is not a tumor. The problem is too much beta cells, so we remove most of the pancreas, and that tends to work. So a gastrinoma is a tumor of functioning gastrin-secreting cells, G cells, and these are located in variable places, in the duodenum most of the time, but it can also be located in the pancreas, and it's located in a region called the Gastrinoma triangle, and I'll show you what that looks like. About 40% of gastrinomas are malignant, so more than the insulinoma. They're more likely to be malignant if they're in the pancreas. The presentation for gastrinoma. So what I want you to get in your head for gastrinoma is the last shoot diagnosis for patients that have refractory peptic ulcer disease. So you have a patient with peptic ulcer disease. What do we do first? Well, we can try H. pylori eradication. If they're positive for that, we try PPIs, we try antihistamines. In a lot of patients, that works. In the few it doesn't work, then we can go on to surgical therapies, and that can be a partial vagotomy or an antrectomy. And in most patients, that works. And in the very, very, very few patients that neither medical or surgical therapy is effective, then we will concern ourselves with gastrinoma. And patients with gastrinoma also tend to have a watery diarrhea. Why do they have a watery diarrhea? They're secreting too much acid. And so that acid is going to find its way into the small bowel. And what's also in the small bowel? Well, you've got your enzymes that are responsible for digesting sugars and fats. And the low pH, the acid, will deactivate the pancreatic lipase, which is responsible for breaking down the fat. So normally, pancreatic lipase is fine. But if the pH is too low, the pancreatic lipase will be denatured and disabled, and so you will not digest the fats properly. And so what happens to those fats? Well, what happens to all fats that aren't digested? You get the steatorrhea and diarrhea from that. So consider a gastrinoma for the patient who's been through anything and everything for peptic ulcer disease, but to no avail. This is not something we go to right away in a patient with peptic ulcer disease. For diagnosing, we can do a fasting serum gastrin level, so that's pretty simple. These secrete gastrin, so we diagnose it by taking a fasting serum gastrin. We do it fasting because in normal people, you don't secrete that much gastrin when you're not eating. And so the fasting serum gastrin level is done greater than 500 picograms per deciliter is suggestive of a gastrinoma. If it's very, very high, in like the thousands, then that suggests a malignant gastrinoma. And once we suspect gastrinoma from the fasting serum gastrin level, we follow that by a CT scan to locate the tumor. So this is the gastrinoma triangle. And the gastrinoma triangle is made up of three imaginary anatomic lines. So the first one, we have a line formed by the junction of the cystic duct and common bile duct. We have another line that's formed by the convergence of the the neck and the body of the pancreas. So right here, and then another point right here, which forms a line from the convergence of the second and third part, basically the descending and transverse part of the duodenum. So just think of your 3 points: head and neck of the pancreas right here, convergence of the cystic and common bile duct here, and then the junction of the second and third part of the duodenum. And just draw a triangle, and this is the place where a gastrinoma is most likely to happen. So remember, though, more importantly, I would say that they're most likely to occur in the duodenum. If they occur in the pancreas, they're more likely to be malignant. The treatment for gastrinoma is a surgical resection, but this is very difficult to do. They're difficult to find. They're usually small, and they're usually metastasized or in multiple places, locally spread. And so this is really only possible in about 20% of cases, but what you can also do is a total gastrectomy, which will reduce the amount of acid that you'll have in the digestive tract. And with malignant disease, you pretty much can't do anything for it other than control the symptoms with proton pump inhibitors, which you were probably doing already. Okay, so other tumors of the endocrine pancreas. So these are much more rare together. Remember that the Insulinoma and the Gastrinoma together make up about 80% of all of these. But it's worth knowing, having a working knowledge of what these are. So the VIPoma is a tumor of vasoactive intestinal peptide secreting cells. And what is vasoactive intestinal peptide? It's kind of like a motility agent, so it moves your intestine along. There is some controversy, or has been controversy, as to whether this is really caused by VIP. And so there are other names for this. Pancreatic cholera, not because it's caused by the same thing that causes an infection of cholera. It's called that because it causes that profuse watery diarrhea that you see in cholera. Or it can be called the WDHA syndrome. And the WDHA syndrome just gets its name from the symptoms. So how easy is that? You just remember the letters. So the symptoms are watery diarrhea, hypokalemia, and achlorhydria. So you get that watery diarrhea because you're moving your intestine a little too fast, so you're not absorbing properly. And then the hypokalemia and achlorhydria, why do we get that? Well, what is in the stuff in your intestine that you're supposed to be absorbing? You have a lot of potassium in it and a lot of chloride from the hydrochloric acid. So if you're not absorbing that, then you're going to have lower levels of potassium, lower levels of chloride, in addition to the watery diarrhea. Diagnosis is via serum VIP levels. About half of these VIPomas are malignant, and usually by diagnosis, if they are malignant, they have already metastasized. The treatment is resection if that's at all possible, but the mean survival after diagnosis is roughly 1 year. The Glucagonoma is a relatively sad disease. It's a tumor of the pancreatic alpha cells, which of course secrete glucagon. And the prominent symptom for glucagonoma is not necessarily what you would expect with Glucagonoma. I mean, what would you expect with high glucagon? You'd expect high blood sugar, but that's not really that symptomatic. The prominent symptom of glucagonoma is what's called a necrotic migratory erythema. And this is this really awful skin rash, which then often becomes secondarily infected. And this has a preponderance to occur in high friction areas. So areas that you wear your pants, especially your underwear, your knees and your buttocks, where you're wearing your watch, if you wear bracelets or necklaces, the shoulders, any area of high friction. And this is really a macropapular sort of ringed blistery-like lesion, which I'll show you. I got some pictures. Some other things that you may see are anemia, stomatitis, which is inflammation around the mouth and inside the mouth, and weight loss, and that's probably because of its malignant properties. Diagnosis, easy enough, is serum glucagon levels. Like I said, the prognosis is poor. We do resection and chemotherapy. You don't need to know what you do for chemotherapy. But other things you can do is octreotide. That can help the skin problems, probably because octreotide suppresses the release of glucagon, but don't quote me on that. And then a high protein diet helps these patients as well, as they tend to have low levels of amino acids. And then finally, the somatostatinoma. I'm not even really going to go into this at all. It's extremely rare, only about 1 in 40 million. And so what does that mean? There's probably about 100 people in the world that have this, 150 people in the world that have this right now. So this is just a somatostatin tumor. And it's really not that well studied because there's so extremely few people who have this. Okay, so this is the necrolytic migratory erythema that you see in glucagonoma. So what I want you to pay attention to here are that you've got these maculopapular lesions that look like something that you might see in other infections of the skin, but you also see these blisters. And these are blisters that have ruptured. So you see those in addition to the maculopapular rash. And you also see some ringing around it too. And they tend to crust over, and they may get infected as well. Here you can see sort of the calves, buttocks, hips. Those are high friction areas if you wear clothes, which most of us do. You can also see some stomatitis, probably, maybe not. And then, of course, these are the blisters that have ruptured. Again, more high friction areas, underwear, pants, shoes probably. All right, so if you have any questions, feel free to let me know.